Mesenteric lymph node dissection in small bowel mets, extent and impact. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon. And if you or someone you care about has been diagnosed with a small bowel neuroendocrine tumor and is facing surgery, you're in the right place. I know the technical aspects of mesenteric lymph node surgery can feel overwhelming, but today we're going to break down exactly what surgeons consider when removing lymph nodes around your intestine. By the end, you'll understand why this surgical controversy exists, what the evidence actually shows about aggressive versus conservative approaches, and what questions you should be asking your surgical team about their experience with these complex procedures. Before we dive deeper, let's establish what we're dealing with. Small bowel neuroendocrine tumors, or SNETs, are unusual growths that typically start small, but have a strong tendency to spread to nearby lymph nodes in the mesentery. The mesentery is the membrane containing blood vessels that supplies your intestines. What makes this surgical decision challenging is that these lymph nodes sit right next to the superior mesenteric vessels, essentially the main blood supply highway for your gut. Remove too aggressively, and you risk compromising blood flow. Remove too conservatively, and you might leave disease behind. This matters personally because research shows that in experienced centers, complete resection of primary tumor and regional lymph node metastases can be achieved in up to 80% of cases. Here's what the evidence tells us. Around 80 to 88% of patients with small bowel nets already have lymph node metastases at initial diagnosis. That's not a small number. Think about it this way. If you gathered 10 people with this diagnosis in a room, 8 or 9 of them would have tumor cells already present in their mesenteric lymph nodes. Research published in multiple studies confirms that resection of at-risk mesenteric lymph nodes is associated with improved survival. Here's where it gets interesting. The optimal number of lymph nodes to remove remains controversial. Some studies suggest at least 8 lymph nodes should be examined, while others haven't found this threshold as critical. What the surgical gold standard now recommends is a vessel-sparing lymphadenectomy, with at least more than 8 lymph nodes removed, aiming to limit the extent of small intestine resection. The traditional approach was called the pizza pie resection. Imagine cutting a wedge-shaped slice from the center of the mesentery out to the bowel, removing a large segment of intestine in the process. This technique often led to excessive bowel loss. The modern approach is called retrograde vessel-sparing lymphadenectomy, and recent retrospective studies show this technique shortens the resected bowel specimen by about half compared to the traditional method. Instead of cutting large wedges, surgeons work backward from the lymph nodes, carefully preserving blood vessels. Multiple synchronous tumors, meaning more than one tumor at different spots, are found in 40 to 60% of patients and usually are not detected on preoperative imaging. That's why manual palpation of the entire small intestine during open surgery remains important. The number of metastatic lymph nodes is the main prognostic factor and determinant of disease recurrence after radical surgery. Let me make this concrete. Patients with more than 4 metastatic nodes have a 3-year recurrence-free survival of 80%. Compare that to 90% for patients with 1 to 3 involved nodes and 93% for those with 0 nodal metastases. 5-year recurrence rates of 30 to 40% are reported in retrospective series. You can do the math. That's roughly 1 in 3 patients experiencing disease return within 5 years after surgery. The prognostic role of lymph node positivity and the number needed for accurately staging have been studied extensively, with findings published in major surgical journals. Now, you might be wondering about the risks of aggressive lymph node clearance. The definition of surgical resectability takes especially into account the degree of arterial involvement by lymph node metastases, according to the Orval classification. Small intestine nets with stage 3 nodal involvement, meaning deep encasement around the superior mesenteric artery, might be difficult to resect, whereas stage 0, 1, or 2 nodal involvement are generally considered resectable. The possibility of performing successful radical resection with adequate lymphadenectomy is strictly related to the localization of superior mesenteric vessel encasement. In experienced centers, only a minority of patients have large mesenteric mass lesions that cannot be completely resected or debulked. But here's the critical point. Resection of large mesenteric metastases may not be possible or appropriate, especially in an emergency setting when performed by surgeons without adequate experience. This brings us to the heart of the surgical debate. The aim of surgery is to perform a systematic lymphadenectomy while avoiding short bowel syndrome, a devastating complication where you don't have enough functioning intestine to absorb nutrients properly. Recent evidence from 2022 published in Cancers suggests vessel-sparing lymphadenectomy should be performed in small intestine neuroendocrine neoplasms. An open approach allows optimal exploration of the entire abdominal cavity and vascular control at the origin of superior mesenteric vessels. Minimally invasive surgery for small bowel nets remains controversial, since an open approach has proposed advantages such as manual palpation of the entire small intestine and safer vascular control, especially when performing vessel-sparing lymphadenectomy. Patients with symptoms due to mesenteric involvement should always be referred to specialized centers for surgical exploration, especially for reoperations. This isn't just academic preference. The evidence is clear. Centers performing high volumes of these procedures demonstrate better outcomes. A laparoscopic resection could be attempted only in the absence of gross lymph nodal masses, or lymph nodes, around the superior mesenteric artery axis. The role of the laparoscopic approach should be limited to early forms without gross nodal involvement. What this means for you: if preoperative imaging shows significant mesenteric lymph node disease, you should be discussing your case at a center where surgeons regularly perform these complex dissections. So here's your bottom line. Let's talk about the 3 categories of action you can take. Schedule a consultation specifically to discuss the extent of your lymph node involvement. Bring your most recent imaging studies, CT scans or functional imaging with gallium-68 dotatate PET/CORT. Ask your surgeon directly, how many of these operations do you perform each year? And what is your approach to mesenteric lymphadenectomy, traditional or vessel-sparing? If your tumor shows stage 3 nodal involvement on the Orval classification, ask whether your case should be reviewed at a specialized neuroendocrine tumor center. Here are sample questions to bring to your next appointment. Based on my imaging, what stage is my mesenteric lymph node involvement? Will you be performing a vessel-sparing lymphadenectomy? How many lymph nodes do you typically retrieve during this operation? What is your institution's experience with preventing short bowel syndrome? Should I get a second opinion at a high-volume NET center? These aren't confrontational questions. They're essential for informed decision-making. Seek immediate surgical consultation if you develop severe abdominal pain or signs of bowel obstruction. These can indicate mesenteric involvement causing complications. After surgery, watch for symptoms of short bowel syndrome, including severe diarrhea, dehydration, or unintentional weight loss. If you are being told you need emergency surgery and you haven't been evaluated at a specialized center, request transfer if medically stable. The data show emergency operations by inexperienced surgeons have worse outcomes. Let me quickly recap. Mesenteric lymph node dissection in small bowel nets represents a delicate balance between oncologic thoroughness and preserving intestinal function, with vessel-sparing techniques reducing bowel resection length by half while maintaining adequate cancer clearance. Your next step: confirm your surgeon's specific approach to lymphadenectomy and their annual case volume for this exact operation. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here that you may find valuable for further information on this topic, including the European Neuroendocrine Tumor Society 2024 guidance paper for the management of well-differentiated small intestine neuroendocrine tumors, studies on vessel-sparing lymphadenectomy published in Cancers, and research on prognostic factors from the World Journal of Surgery. Full links are in the description below.